So the addition of daratumumab to earlier and earlier lines of therapy has really changed, I think, the way we think not only of the newly diagnosed patient, but of the relapse setting, because now patients who maybe are in their second line of therapy may be refractory to a CD38 agent. The field is absolutely changing. We not only have the elderly data, such as the MAIA adding daratumumab to lenalidomide and dexamethasone. We now have data both from the US and Europe, namely the Griffin study in the US, looking at the addition of daratumumab to the triplet combination of lenalidomide, bortezomib, dexamethasone, which I think is really the standard of care at the moment. And similarly, the Cassiopeia study looking at bortezomib, thalidomide, and dexamethasone with the addition of daratumumab. And so using the baseline of different geographic locations, again showing a drastic benefit to the addition of a fourth drug. Ultimately, I'm not sure every patient will need a quadruplet therapy up front. I think patient selection will ultimately need to be taken into account. We still have patients who respond well to combinations of bortezomib, cyclophosphamide, and dexamethasone, even though that's fallen out of favor considerably. And so eventually being able to find which patient requires what therapy or will benefit mostly, tolerate best, will be very important. And not forgetting to take into account the financial toxicity of putting this many patients on quadruplet therapies, especially as our current paradigm is really for continuous therapy. And as patients have very long responses, very deep responses, it will be interesting to see how we manage all of that over time. It's interesting, daratumumab and isatuximab target different epitopes on CD38, and so there is precedent in, say, solid tumors where you would use two monoclonal antibodies on the same target. I'm not sure we need to be doing that in multiple myeloma. I think sequential use of similar entities and drugs would be maybe a little bit more advised at this time. We now have data, as I had mentioned, with the daratumumab and bortezomib, lenalidomide, dexamethasone. There is now quite a practice in the United States of using carfilzomib, lenalidomide, and dexamethasone in the frontline setting as well as in the relapse setting. And it will be interesting, I think not surprising, that the addition of a CD38 antibody will deepen that further. We also have interesting data of the combination of CD38 antibody added just to a carfilzomib dex combination, maybe our most powerful, but since so much of our data comes from IMiD-containing regimens, having an IMiD sparing, it's interesting again for the patients who maybe are intolerant or benefit further. So patient selection will come into this. Do we need to have all four, or can we tease out which triplet would be advisable for different patient populations? It's exciting to have the Icaria data, and likely this is a combination that will lead to an FDA approval, adding this to our armamentarium of drugs. It will be interesting to see where it will fit, which patients exactly, and how the two different CD38 antibodies reach the market, both as far as reimbursement, as far as infusion times. I think with the daratumumab, many of us have moved down to a 90-minute rapid infusion based on data that's been presented. Soon we expect to have a subcutaneous formulation. So the timing, the combination, and the prior therapies will all come into play. I think I've been saying this now for 10 years. Every year we make such strides in not only understanding more about the pathophysiology, but translating that into therapies that are changing patient outcomes. CD38 will remain one of the big targets, I think not only in monoclonal antibodies, but as I mentioned, there are a few CAR T therapies coming up, both in combination with BCMA, or new combinations as we come up with better and better ways of targeting myeloma.